One of the things that neither of you actually covered, which I think is an interesting aspect in the field right now, is the work of Shaheen Rafi. So maybe one of the, or both of you can comment on this. Since for people in the audience who don't know about this, what he's been saying is that perhaps a major way that blood vessels and activated endothelial cells can promote tumor growth is not by the Folkman hypothesis, providing oxygen and nutrients and so forth, but by a so-called angiocrine hypothesis, that these endothelial cells are like little factories producing a whole myriad, a spectrum of different cytokines, chemokines, growth factors that can have an effect on tumor growth, promote tumor growth, and other aspects of tumor progression. His view is that maybe we've overemphasized the role of oxygen delivery and nutrient delivery. It's the cytokine, angiocrine response. So any comments on that?
I think that this is an interesting aspect of the story, and is already, as I was saying, is already known in the hematopoietic system, where endothelial cells can really cross-talk with the hematopoietic cells, and is a very nice environment. As I said, for instance, in what we are working on myelofibrosis is very interesting, is a primary myelofibrosis. And the megakaryocytes are completely altered functionally and morphologically. And you can see that there is a direct interaction between megakaryocyte and endothelial cells, and also endothelial cells are affected. So this crosstalk, I believe that it makes a lot of sense. And vascular cooption may be probably a condition of interest, because this means that probably the endothelial cells release chemotactic.
I believe it is also important as well. No, absolutely. I think the vasculature can certainly have the potential, and there is data suggesting that it delivers factors. So to come on to your point, yes, we had considered that possibility also. One possible mechanism is that the endothelial cell orchestrates the growth of the tumor cells along the vasculature. And in fact, there is evidence in development of the liver and lung that actually the endothelial does coordinate the endothelium is laid down, and then the epithelium actually grows over the vasculature. And actually, if you think that in a cancer, in a cancer, the cancer cells are the epithelium, it's not a great leap of imagination to imagine that, yes, endothelial factors could be organizing the cancer cells around them. And yeah, I think it's a very good idea.
I think, another point that's been raised in the your presentation, Andy, and then one of the questions is, what has happened in the area of adjuvant therapy with antiangiogenic drugs? And as you pointed out, you mentioned there are something like 4 or 5 trials. It's actually up to about 8 now, 7 or 8.
I knew you'd correct me on that one.
Right. So the last one was announced a couple of weeks ago at ASCO GU. It was in renal cell carcinoma. And the drugs used were sunitinib and sorafenib. And obviously both of these drugs have been successful, in the metastatic setting in renal cell carcinoma. So now comes along this trial, SURE it was called, and the results are negative for disease-free survival. But, I think the interesting thing about almost all these trials, and it's something I think we have to think about, they're negative. The primary endpoint clearly is negative. But if you look at the survival curves, and virtually every one of these trials, there was a benefit while patients were on therapy and for a certain length of time after therapy was stopped. What happens is that there's some sort of a fading effect. And in one case, in colorectal carcinoma, the AVANT trial, there was actually a crossover, and the patients, there was a trend towards a worse outcome as a result of having received chemotherapy plus Bev, and then maintenance bevacizumab. So maybe we should think about what is the basis of this fading effect. Some people have argued that maybe if we prolong the duration in the adjuvant setting of antiangiogenic therapy, which has certain downsides, toxicity. A lot of patients in adjuvant trials are already cured. They don't need any therapy, so we're faced with the dilemma of prolonging therapy in a substantial number of patients who don't need anything. And then there's, of course, the toxicity issue as well. But any comments about, from either the audience or you guys, about this really peculiar dilemma that during the therapy phase and shortly afterwards for a period of time, these drugs actually seem to work, and then there's a fading effect and the benefit is lost?
Yeah, you're right. It is a really good point. So I've seen that data too, and that would be consistent. I mean, and it does make a lot of sense, absolutely, that whilst you stay on the drug, you see benefit, because essentially the drugs are cytostatic. They're blocking the vascularization process, and then when you come off, you lose that effect. So I think biologically, yeah, it does make a lot of sense. But I think you're right. The problem is, how do you can you justify giving these drugs which are not without toxicity for 3 years, 5 years, 10 years? But now we're seeing in breast cancer the recommendation is 10 years tamoxifen, right? So in the adjuvant setting, so perhaps there is a precedent for giving these drugs for that long, or maybe you could modify the regime to a low dose regimen or something like this to make it more tolerable.
Right. Yeah. I mean, with tamoxifen, you're dealing with, I think, a safer drug and obviously a much less expensive
Obviously,
drug.
yes. And obviously, I mean, I guess a lot of drug companies are quite keen on the idea of giving antiangiogenic therapy in the adjuvant setting for 5 or 10 years, but whether it's feasible in the economic health of the health system, I don't know.
Any questions from the audience? Yes.
What do you think of the prospects of targeting parasites in combination with endothelial cells in order to achieve either vascular regression or vascular normalization, or maybe to overcome resistance to traditional antiangiogenic therapy targeting only endothelial cells?
So there are few data done with this. Depending on the type of tumor, essentially the vasculature is relatively poor in parasite. So there is a reduction in the number of parasites that probably go together with the vascular destabilization. Targeting parasite might be interesting. It might be probably difficult to find some sort of specific markers to direct the therapy to the parasite or some specific function of these cells. The point is that if you kill the parasite or you inhibit the interaction with endothelial cells, you would increase the, let's say, the abnormality of the cancer cells, of the cancer vascular cells. And if you increase the recruitment of the parasite, so for instance, I mean, I'm just dreaming, I mean dreaming because tools are not yet in our hands. For instance, inducing the endothelial cells to produce the PDGF or other growth factor that might recruit parasite. This has to be tried.
Yeah.
But I would just add that the role of parasite is still highly, highly debated. So it's sure that when you see them around the vasculature, the vessels are more stable. But whether this is an action of parasite directly, whether there are other sort of growth, this, to my view, is still quite open.
Yeah, I think you're right. I think it's actually quite complicated. There's actually some studies suggesting that, yes, if you hit parasites as well, this could be really beneficial. You reduce tumor growth because you hit the vasculature harder. There's also some other studies suggesting that if you block parasites, you actually promote metastasis. This is a paper from Raghu Kaluri. And actually, I think it's probably dependent upon the disease setting. So actually, there's some very interesting data. People looked at parasite coverage in colorectal cancer and breast cancer. And if my memory serves me correctly, low parasite coverage in those cancers is associated with a worse outcome. But in bladder and renal cancers, it's the opposite. If you have low parasite coverage, you actually do better. And so that suggests that it's probably disease context dependent. And I think it's disease context dependent. So you could imagine actually that hitting parasites in renal and bladder cancer could be very good. And in fact, sunitinib probably hits them. It hits PDGF and probably hits the recruitment. But in the other cancers, perhaps their biology is different and it could make things worse. So It's difficult, I think.
Let me give a bit of a historical perspective on that question, because I think it's very important what you've asked. When the tyrosine kinase inhibitors were being developed by companies, by many companies such as Pfizer and Bayer and so forth, all these TKIs, they virtually all target, of course, not only VEGF receptors but PDGF receptors. And the first study that I'm aware of that came out that said, it would be a good thing from an efficacy point of view to target both pericytes by targeting PDGF receptors and endothelial cells by targeting VEGF receptors, came from Doug Hanahan's group when he was in San Francisco. And what he did was, by using a number of different drugs which either targeted PDGF receptors like imatinib but not VEGF receptors, or another drug that only targeted the reverse, so you could put the two drugs together and ask whether they would work in combination better than either drug alone. The results looked very good when treating primary tumors in mice, okay? So after that paper came out, from my perspective, there was a view for a little while that targeting pericytes via PDGF receptors and targeting endothelial cells, primarily by targeting VEGF receptors, was a good thing. And actually, the first study that questioned the validity of that assumption came from a group at the Karolinska Institute in Stockholm, Christoph Beschels. And what he said, by doing genetic knockout and other sorts of experiments, is that if you actually disrupt pericyte function, you make the vessels more permeable, dysfunctional, and allow tumor cells to extravasate and intravasate more readily, and therefore could actually promote rather than inhibit metastasis. And then you've mentioned Raghu Kaleri's work. There's work by other groups as well that have now really questioned the validity or the usefulness of targeting pericytes, and that may be one of the limitations of the TKIs, is that actually you probably don't want to do that. And I wanted to mention that for another reason, because this also highlights the way preclinical experiments are often done. The Hanahan study, which was very elegant, looked at the impact of targeting pericytes and endothelial cells in a primary tumor treatment setting. That's it. Didn't look at metastatic disease. Well, when you start to look at metastatic disease, then you might get a discordance, a disconnect between what you see in the primary tumor setting and what you actually get with respect to distant metastatic disease. The outcomes can be completely opposite, diametrically opposite. So my own view about that is that I really don't think that targeting pericytes is a beneficial thing.
May I just add one word on this?
Yeah.
I think that it's difficult to remember that the vessels are different. I mean, this is what I was trying to tell you with my talk. I mean, the vessels are strongly, strongly influenced by the environment. There is a continuous crosstalk, so they change continuously. And the tumor is like an organ. So how the brain can certainly determine the function and the morphology of the microvasculature, then the tumor can strongly influence the type of vessels that perfuse them. And so I think that this is something that we have to work on much more. Yeah. And probably we have to develop good system, even in vitro, of crosstalk, of co-culture, of the different type of cancer and so on. Because otherwise, I mean, even if to my view is very human to try to find a general concept that might be transversal for all the tumors, this is, to my view, is not possible because the physiology tells us that you know, in embryo development, indeed, the vessels are different. The endothelial cells are totally different. And so this, I think, should be considered also considering cancer.
I wanted to ask you about the combination with chemotherapy. And the question is, what about sequential, like first anti-angio and to normalize, for instance, and then chemo, or vice versa, first chemo that makes something to the vessels and vice versa. And in the eye, they work alone. So the Lucentis or Avastin in macular degeneration or whatever are very effective as a single drug. So what is the, histopathology or whatever of the vasculature in the eye where it works by itself?
Okay. I might even direct this to Bob. I think the puzzling thing is why, if you look in the literature, you have all these mouse models where you put a tumor subcutaneously in mice, and you give a VEGF-targeted antibody on its own, and the tumor just doesn't grow. It completely inhibits the growth of the tumor. And yet, as far as I'm aware, perhaps there's some evidence in ovarian, but I don't know, in almost every metastatic cancer where the VEGF-targeted antibodies, bevacizumab, was tested, they never saw single-agent activity. You only see activity when you give it with chemotherapy. And I don't think it's clear why that is the case. I think targeting VEGF somehow sensitizes to chemotherapy, perhaps, but I don't think we know why. I mean, in the eye, it's different because you just want to target the vasculature, whereas in the cancer, you want to target the vasculature and the cancer cells. So there's an extra level of complexity there which is not captured in the setting of the eye.